Let me begin by saying thank you. Thank you to the Lancet and to Jonathan Pym for the invite to write a State of the Science paper on insomnia. It was and is an honor. Thank you for the invite to this symposium. To those in attendance, thank you for your interest. I wish I could be there with you. Since most, if not all of you, are sleep medicine and sleep research experts, please allow me to bottom line the subject matter from our paper and then provide some things to ponder, which were also covered in the paper. As far as the bottom line is concerned, let me just give you a list first. Insomnia is not a symptom, it's a disorder. Insomnia should be treated. The first-line treatment for insomnia when acute or subchronic may be medications. The first-line treatment for insomnia when chronic is CBTI. Insomnia treatment is likely to positively affect co-occurring medical and psychiatric symptomatology. So, maybe the question nowadays is, when is CBTI not indicated? Let's take these one by one. Insomnia is not a symptom, it's a disorder, aka insomnia disorder. For most of sleep medicine history, if not the last 100 years, the call to arms was the opposite. It was insomnia is a symptom, not a disorder. Let me say that again. Insomnia is a symptom, not a disorder. It's like fever or pain. For example, in 1887, Otto Wetterstrand said, sleeplessness is no disease in itself, but a symptom of disease. It may be present in all diseases and commence and end with them. The concept of primary and secondary insomnia was called into question over a series of theory and review papers, the first of which I think was McCrae and Lickstein, and then Stepansky and Rybarczyk, and then in a commentary by Ken Lickstein entitled Secondary Insomnia, a Myth Dismissed. I think this paper is the one you absolutely should read. Ultimately, the utility of the primary insomnia versus secondary insomnia distinction rested on the assumption that secondary insomnia would not be responsive to CBTI, that treatment outcome would look something like this. So what you see in this fake data, what you see in this graphic is the intrinsic insomnias. Here you see psychiatric insomnias, if you will, and here are medical insomnias. And the idea is that it may be true that CBTI is indicated here for the intrinsic or primary insomnias, but you won't get much bang for your buck in the medical or psychiatric insomnias. Ultimately, the issue was settled given the accumulated evidence that CBTI is absolutely effective for secondary insomnia. Absolutely as effective for secondary insomnia as primary insomnia. There have been so many studies that there are now 7 meta-analyses, all of which say the same thing. First, CBTI is effective in patients with secondary insomnia, but they may go further. They may say CBTI in secondary insomnia is as effective as it is with primary insomnia, or in rare cases, but they certainly have occurred, CBTI in secondary insomnia is more effective than in patients with primary insomnia. So if we look at our graphic again, you can imagine that all the bars hover around the 50% pre to post change mark, and that what we expected to occur didn't occur. Next proposition, insomnia should be treated, ideally with evidence-based therapies. The case for treatment is based in part on the existence of effective treatments, and in part on the preponderance of evidence that untreated insomnia is consequential, exists as a risk factor for new onset and/or the exacerbation of medical and psychiatric comorbid illnesses. So something like this. Next proposition, the first line treatment for insomnia when acute or subchronic may be medications. This is somewhat controversial, and is really a matter of speculation on our part, but it stands to reason that early interventions with medication may require less treatment, and such interventions may prevent the behaviors and cognitions that transition acute insomnia to chronic insomnia. So like this, if you see acute insomnia over here on the left, what we are saying in a very Spielmanian way is that there are perpetuating factors that transition acute insomnia into chronic, and when they are absent, allow patients to recover good sleep. So the idea is, can we target these perpetuational factors with medication early on to prevent these behaviors and cognitions from occurring? So for example, the primary behavioral factor, the mortal sin behavioral factor, is considered sleep extension. Can we prevent that? Alternatively, can we promote or prevent rather the failure to sleep restrict, which would be the venial sin that transitions acute to chronic insomnia? Can these things and others be prevented by early treatment with medication? This said, there is another approach. Alternatively, one-shot CBTI or BBTI, which are more condensed, shorter versions of CBTI. Perhaps these could be used to eliminate the third P. The next proposition, the first-line treatment for insomnia disorder when chronic is CBTI. This came out in 2016 by the American College of Physicians. It was strange and wonderful that this was the first group to promote the idea that CBTI should be the indicated treatment, the first-line treatment for insomnia. And they said, ACP recommends that all adult patients receive cognitive behavior therapy for insomnia, CBTI, as the initial treatment for chronic insomnia disorder. This has since been adopted by the ESRS, the ASA, the VA, the BAP, and the AASM. Next proposition. Insomnia treatment is likely to positively affect co-occurring medical and psychiatric symptomatology. The possibilities include improved cognitive and memory function, improved executive function, less frequent or severe nightmares, reduced depression severity, diminished suicidal ideation, diminished suicidal behaviors, diminished pain intensity or improved pain tolerance, weight loss, improved blood pressure, better glucose regulation, better innate or adaptive immunity, and finally, the possibilities of improved lymphatic function. Presently, there is evidence for CBTI affecting the areas demarcated with an asterisk. Finally, the real question nowadays is, when is CBTI not indicated? The common wisdom in the absence of RCTs was in patients with bipolar disorder, seizure disorders, psychosis, suicidality, autism, parasomnias, and arguably paradoxical insomnia. Nowadays, there is evidence that CBTI can be successfully and safely applied in individuals with most of these disorders, the remaining exceptions being seizure disorders and paradoxical insomnia. And this is an area we could have quite a long discussion, but we'll leave it be. Finally, and absent the primary-secondary distinction, an algorithmic approach has been recommended. Looks like this. It's a lot to digest, but take it at this level. This means, do they have something we can treat? And is there anything about CBTI that would make the comorbid disorder worse? Or is there anything about the comorbid disorder that would prevent us from or force the modification of CBTI? And if the answer to this is yes, and that is no, then CBTI is indicated. How can one find an insomnia specialist or CBTI provider? There is an international directory of CBTI providers. This is something we made because there's a lot of confusion between membership directories and clinician provider directories. And we built this so that providers can extensively profile their skills and their trainings and their credentials in a way that is way beyond any membership directory. We also reference the pediatric sleep providers and provide a link, as well as a link to the SBSM provider directory. But again, in that case, it's more a membership directory. What can one do if a CBTI provider is not available? There's an app for that. In fact, there's a bunch of them. Here's the ones I know of, and it's not an exhaustive list. Shut-Eye, Somrest, Sleepio, Insomnia Coach, Restore, Sleep Tutor, Sleep Rate, Sleep Reset, Sleep Station, Sleepful, CBTIforinsomnia.com, Somly, Night Owl. Where can one get training in behavioral sleep medicine and CBTI? Bunch of places: Oxford, Freiburg, Sleep Consultancy, Ryerson, UPenn, UA, the DoD. There's also some other online trainings through PESI, CBTI Clinician Training, and CBTI Educational Products. Most of those are in English. And so the CBTI, European CBTI Academy, in their infinite wisdom, has made available courses that are not in English. And here's that list. Finally, some things to ponder that are discussed in our paper. Why is chronic insomnia defined by greater than or equal to 3 nights for 3 or more months? Why is chronic insomnia defined without quantitative criteria for DIMS? Why is a daytime complaint required for the diagnosis of insomnia? Why is there no TST criteria for the diagnosis of insomnia? Are the types and subtypes of insomnia of relevance for our prescriptions? How much assessment and monitoring is required for treatment? Is it easier to treat insomnia when it's less chronic? Is acute insomnia better treated with meds? Is one med better than others, especially as a first-line treatment? Is CBTI superior to medication in relation to outcomes for DIMS? Is combined treatment best, meds plus CBTI? How does DCBTI, digital CBTI, compare to therapist-delivered CBTI? And how do the various DCBTI apps compare to one another? Finally, and most importantly, how can we get assessment and or treatment of insomnia into routine practice? So with that said, and without further ado, this is the end. This is my email if you wish to email me, and do you have any questions?